Hello, guys. So today we're gonna be discussing gastrointestinal examination. It's gonna be an easy one, hopefully, and we're gonna try to finish it up quickly and make you understand the basic concepts of how to do a GI exam in your OSCE station. We're gonna start as usual with general exam, then we're gonna go to the actual abdominal exam, which comprises of palpation, percussion, auscultation, just like we did in the chest. We're gonna do it in a similar manner. So for the general examination, we're gonna greet our patient, start our examination with the inspection, only inspecting the general appearance before jumping into examining the abdomen. Check the general appearance of the patient. Is he conscious? Is he alert? Is he oriented? Are they cooperative with you, talking to you? Are they in any distress or any pain? If not, you can move on. Check if they're cyanotic, look at the skin color, and then check for any dehydration signs, which are examples of these signs are decreased skin turgor, velvety skin, sunken eyes, decreased capillary refill. So you would approach your patient and check for these signs of dehydration because it's very important and vital to check for dehydration and treat it as soon as possible. Then for the eyes, you'd have to look for a conjunctival pallor, check for jaundice because we're in the GI exam, so we're going to talk more about the liver cirrhosis signs and the liver function in a bit. And then for the hands, you check, as we said, the capillary refill is very important. Check for a clubbing. Clubbing usually goes with chronic illnesses. Importantly, here in GI exam, you're looking for signs of cirrhosis, so check for clubbing. Do the sign that we talked about in the respiratory exam. So you can check the respiratory exam video for how to test for clubbing. Then going on to the neck, you have to check for any jugular venous distension because again, this goes with the liver cirrhosis signs. Check for carotid pulse, see if he's tachycardic or not. And then for lower limb, finally, check for edema. Again, edema is a sign of cirrhosis. Now, we need to focus more on cirrhosis before we move on to the abdominal exam because it's a very important part of the GI examination is to rule out chronic liver dysfunction in your patient. So start with the hands again in a similar manner to the general exam that you did previously. Here, you need to focus on certain points, mainly, as we said, nail clubbing, then look for the palms of the hand and check for palmar erythema, then check for jaundice, the skin color, and the eyes. Then spider angiomas, and the spider angiomas are these tiny vessels that you can see here. They draw like a spider web kind of thing, and they're actually explained by the vasodilatory effect that the cirrhosis has. There's peripheral vasodilation, and these tiny vessels are usually dilated, and then there will be some kind of like telangiectasia under the skin, forming spider angiomas. The most common site where you can find them actually are in the neck and the upper chest. And then look for gynecomastia, look for breast atrophy. These are all going with, usually these are due to the estrogen abnormalities that happen in cirrhosis. You would get gynecomastia in men, breast atrophy, and then moving on, testicular atrophy as well happens. So you would examine the genitalia and check for testicular atrophy. Then for the abdomen, look for caput medusa. And caput medusa is actually the shape that is that happens as a result of the dilating veins over here under the skin. Once they dilate, they give the caput medusa effect. And then check for ascites. Ascites, as we all know, it needs its own examination. And usually for the mild to moderate ascites, shifting dullness test is adequate. You can percuss from the umbilicus going outwards and check in case of dull. In case of ascites, it would be dull. Then ask your patient to turn to one side, percuss again. If it's resonant, this is called shifting dullness, meaning this dullness actually shifted when your patient turned. And this means that there is ascites. This is a positive sign. And then check for lower limb edema, again, because there's fluid buildup in cirrhosis. And for any signs of GI bleed, most commonly esophageal varices, so they may have some hemoptysis or rectal bleed, and that's going to be when you do your rectal exam. Moving on to the abdominal examination, mainly again inspection, as we said, the same exact sequence that you use: inspection, palpation, percussion, auscultation. For inspection, you would inspect for any distension, as we said, like in ascites. Inspect for surgical scars in the abdomen. There are so many scars you can look for. I attached this for your reference here. You would see the cohort scar, which is the cholecystectomy, open cholecystectomy, not very commonly done nowadays with the laparoscopy, but however, you have to know that this is the classic incision that they do. Then you've got the Mercedes-Benz when there's a transplant, liver transplant, the median laparotomy, which is used usually in emergencies. When you have an exploratory laparotomy, you have to do the median incision. You've got the paramedian one. Usually, if you want to get an intra-abdominal access, there are so many causes to why they may do it. Then you've got the other common one that you need to know is the gridiron incision for appendectomy over there in the right iliac fossa. And you've got the fin and steel, very commonly used in gynecological procedures, and namely the cesarean sections. So these are some of the important incisions. Then you would obviously look for visible veins. Any veins you can see, as we said, the cirrhosis, any hernias or protrusions. You might have some umbilical abnormalities as well, and look for any, you have to comment on any abdominal tubes or drains that you can see. Sometimes you've got, for example, when there's a large midline laparotomy, you can get a vac dressing. The vacuum assisted closure device may be attached. So you have to comment on that in your inspection. Then in palpation, you would divide it in superficial and deep. In the superficial, you have to palpate all 4 quadrants. So imagine that this is the abdomen. You always have to divide it into 4 quadrants. Let's say for the sake of the time, we're going to divide it now into 4. Obviously, there are like 9 divisions that you can get in the abdomen, but we're going to, for the palpation, divide it into 4 and palpate all 4 quadrants, and then deep palpation, palpate same areas deeply and look for specific signs. What are the signs I'm looking for? The signs are either guarding, rigidity, or rebound tenderness. Rebound tenderness is a very common term that you hear usually when you, in the right iliac fossa, specifically in cases of appendicitis, for example, when you put your hand and deeply press or palpate, and then once you remove your hand, the patient will scream in pain, or he will express that they're actually in pain. This is called rebound tenderness. And then rigidity and guarding are 2 similar terms, but there's a very core difference. In guarding, it's the voluntary contraction that can happen as a result of you palpating. And this usually happens when there's peritonitis, but it's an early kind of inflammation. The process is still early. For example, there is peritonitis, there is some kind of intestinal perforation, let's say. It's causing peritonitis, but it's early in the process. So the patient will have voluntary guarding. So once you put your hand, they will try to guard, and the muscle will contract voluntarily, and they will withdraw as if the abdominal muscle is withdrawing from pain. While rigidity, it's involuntary contraction that happens the moment you put your hand, and usually the more rigid the abdomen, the worse the peritonitis is. This means that there's late, profuse peritonitis all over, and means that this patient needs immediate surgery usually. So rigidity is the involuntary contraction of the muscles, and then guarding is a voluntary contraction while examining. For the liver and spleen specifically, while palpating deeply, we're actually palpating, you go from the right iliac fossa up to the right upper quadrant, and you have to check for the liver if you can palpate it below the costal margin or not. And the same thing applies for spleen. I would go from the right iliac fossa going up towards the left upper quadrant and check if there is splenomegaly. How will we do that? For the liver, we'll start palpating the right iliac fossa and then go up, 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 and then percuss as well. It's expected to get dull just below the costal margin. To determine the exact span, you have to percuss and palpate at the same time. So after you palpated down and then going up, you have to percuss from the chest, the second intercostal space, going down. It's expected to be resonant, obviously, over the lung. Then once you go down, down, down the nipple and you feel the dullness, this is where the liver starts. So draw a point, for example, it started here. Draw a point where you started hearing it dull and go down, down, down until the dullness ends and it becomes resonant again. And this makes the span of the liver. So this from here till there is the span of the liver. Okay, this is how we measure it. And the normal span is 7 to 11 centimeters in an adult. For the spleen, again, we're following the pattern of enlargement. This is how the spleen enlarges. So it enlarges like this obliquely. So you would start from palpating in the right lower quadrant and go up. And then while doing that, keep palpating a little until you reach the left costal margin. This is how the spleen enlarges. Normally, you wouldn't be able to palpate it below the costal margin unless there's an enlargement. And then if you can't feel it and you actually suspect that there is splenomegaly, ask the patient to turn to the left side and repeat the exact same process. Keep palpating until you feel something. For percussion, again, we're going to percuss all 4 quadrants. Obviously, in the abdomen, since it's filled with gas, you would expect a resonant note, but dullness can be heard over the solid organs, such as spleen and liver, as we just explained, or over masses. Then for auscultation, the main thing you're looking for here is either a bruit or the bowel sounds. Bowel sounds, normally you would get a one sound minimum in 2 to 5 seconds. So try to listen carefully and then take 5 seconds minimum to hear one sound. If they've got exaggerated sounds, this may indicate early obstruction. So in early bowel obstruction, the obstruction worsens the gargling sounds in the abdomen and it exaggerates. And then when it's severe, or late, then you would expect to get absent, no sounds at all. For decreased bowel sound per se, usually it goes with bowel ischemia. This is one of the important diagnoses that you would think of in decreased bowel sound, but it may be a normal physiological finding in some people. And for abdominal bruit, check for renal artery stenosis, or like this is the differential that you would think of if you found a bruit in the para-umbilical area. Either AAA or abdominal aortic aneurysm or renal artery stenosis, both can give you a bruit. A bilateral bruit usually is heard in a renal artery stenosis if there's bilateral renal artery stenosis. Finally, for digital rectal exam that you have to end your abdominal exam with, it's a very important step. Don't forget it. You would do it with only one finger. So you would lubricate your index, wear your gloves, lubricate your index finger, and insert it while your patient is lying obviously on one side, so he would be in a lateral decupitous position, and then you would insert your finger and try to take a turn and then feel the whole all the walls of the rectum and check for bleeding, check for any masses felt when you palpate, and in males you have to check over the anterior wall, check for any prostate enlargement, and check the consistency of the prostate. We've got some special tests that I would like to tell you about to end this examination, which are the appendicitis signs and the cholecystitis signs. I mean, you may probably heard of the Murphy sign in cholecystitis. It's just the rebound tenderness that we get in the right upper quadrant. So again, we're gonna draw the 4 quadrants. In the right upper quadrant, what you get rebound tenderness, and actually the patient stops. They wouldn't be able to continue taking a deep breath. This is called Murphy's sign. In appendicitis, we've got a little bit more of one sign. So we've got McBurney's point, or which is the rebound tenderness or the pain that you get in the McBurney's point. McBurney's point is over here. If this is the inguinal ligament, it's midway between the anterior superior iliac spine and the symphysis pubis. This is where the McBurney's point is, so the pain would be somewhere here. Rebound tenderness in the right lower quadrant is another sign. Rovsing's sign, in which you've got pain in the right lower quadrant when you press on the left lower quadrant. So the examiner's hand is on the left lower quadrant, the patient complains of pain on the right. Then psoas sign is pain in the right lower quadrant when you ask a patient to extend their hip. So you can ask them to turn themselves to one side, and you would extend their hip, and then during this extension process, they would get pain. Obturator sign is usually pain in the right lower quadrant when they flex or internally rotate the hip. And you would passively do this to the patient, ask them to lie down, then you would hold the hip and rotate it internally and see if they get pain or not. This is again going with appendicitis. All these signs obviously depend on the site of appendix. So some people have an obturator appendix near to the obturator muscle, so you'd get these signs. Some people have it in the psoas area or near the psoas muscle, but these are generally signs of appendicitis. And that wraps up our presentation for today. Thank you for watching.